Hello and welcome to today's webinar focusing on service and resource sharing approaches to data modernization. This is the first webinar in a two-part series, and we're excited for you all to be joining us today. We are able to host this event through Public Health Infrastructure Funding or PHIG funding, and FAB would like to express gratitude for the CDC's commitment to strengthening public health infrastructure nationwide and allowing us to provide this type of programming to the field. Before we dive into our topics today, I wanted to share just a few general logistic reminders. Participants are automatically muted, so please use the chat to enter any questions or to connect with other participants. Time will be allocated at the end to respond to any questions that we receive. And this session will be recorded and shared either in a follow-up communication and will be posted on our website as well. Lastly, I did want to note that closed captioning is available within the Zoom window should you wish to turn that setting on. To enable closed captionings, click on the CC button in the meeting toolbar as shown in the screenshot. And please note that this may vary slightly depending on the version of Zoom that you're using, but you can also hide captions at any time by clicking on the CC button again. So we have a wonderful group of presenters today who are subject matter experts in either service and resource sharing or data modernization. My name is Travis Parker Lee. I use he, him pronouns, and I am a senior specialist at the Public Health Accreditation Board, or FAB. I'll be acting as the moderator for today's webinar. Our first presenter is Grace Gorenflow, who is working with FAB as a consultant on a variety of topics. With over 30 years of experience in governmental public health, she specializes in service and resource sharing, public health system and agency transformation, accreditation, and the intersection among them. In addition, she has experience in community health improvement planning processes with a focus on health equity and racial justice, and public health agency quality improvement and performance management. You may know Grace from her years at the National Association of County and City Health Officials, where she worked for 20 years before launching her consulting firm in 2011. And she is currently an adjunct professor at Pennsylvania State University. Our next presenter is Walisha Jenkins, who serves as the Senior Advisor for Data Modernization and Informatics at FAB. In this role, she supports FAB's data modernization initiatives, plays a key role in launching the Public Health Data Modernization Implementation Center program, it's a mouthful, and leverages her expertise in informatics strategy, equity-focused programs, and capacity building to strengthen public health infrastructure. Walisha previously worked as the Data Modernization Director at the North Carolina Division of Public Health, where she led the Centralized Health Equity Data Initiative and established the state's first historically Black colleges and universities Health Equity Data Consortium. And our final presenter is True Taylor, who is the Director of Health Data Analytics at Guidehouse and is the technical lead for the Guidehouse Implementation Center, one of the 3 public health data modernization program centers, which we'll hear more about later on in the presentation. She leads public health data modernization and enhanced interoperability activities to support federal, tribal, state, territorial, freely associated states, and local public health organizations. True leverages her past experience in laboratory science, surveillance epidemiology, and informatics at health departments to support acceleration of health data exchange across the public health ecosystem. So hopefully you can see we have a breadth of knowledge from our 3 speakers today, and they're very excited to share more about service and resource sharing and data modernization. While we go over the next couple slides, if you want to go ahead and introduce yourselves in the chat, just let us know who you are, where you work, and where you're zooming in from. So here are the objectives that we will cover today. I'll give you all a quick moment just to review them on your own. And then here's how we'll spend our time together this afternoon. As a reminder, feel free to enter questions you may have into the chat anytime, and we'll address those during the Q&A portion of the webinar. So to kick us off, I'll turn things over to Grace.
Thank you, Travis. And hello, everybody. I'm glad you all could join us today. So I am just going to talk for a couple of minutes about service and resource sharing. And this slide shows you our definition. And so essentially sharing refers to staff insights, expertise, techniques, and/or tools being shared across organizational boundaries. And you can see here on the slide a few different reasons that sharing can be very beneficial and why health departments might decide to share. I think that the bottom line, the take-home message is that it's usually done because health departments coming together can accomplish more than what any single health department can do alone. And this is true whether you're looking to expand expertise, if you're looking to create efficiencies, if you are interested in innovating, whatever it might be. But this is what guides us in our work and grounds us when we think about sharing. All right, next slide, please. We created a couple of different frameworks to bring even more clarity to sharing and the many ways that sharing can occur. And we've done this for a few reasons. Hopefully this helps expand your own horizons and your own thinking about different ways that you might look to share services. It also helps health departments see that sharing is likely already occurring in their jurisdiction with a neighbor, with the state, if you're local, maybe even between states. And we've seen that that understanding can help minimize any apprehension that some people have when it comes to starting a sharing arrangement. And then also we think it's good for the practice community to get a sense of the different scenarios that can benefit from our tools and our expertise. Something else that I think is important to mention now is that we have not found it helpful to categorize every sharing arrangement that we come across, and we certainly don't try to do that for those in the practice community. The reason is that these approaches are not exactly scientific definitions, and there aren't always crisp distinctions. It is quite possible that one arrangement could actually be considered in more than one category. Rather, it is just to help people conceptualize what we're talking about. So you can see that with respect to sharing approaches, we've got 3 different types of approaches, starting at the state level or the system level. And this happens when a single entity, and it could be the state health department, it could be a different agency, either comes up with a strategy to promote sharing among local health departments in the state, or actually there's one entity that provides a public health service across the entire state. When we look at regional district approaches, this happens when a service is shared by an entity for a defined subsection of a state. And then finally, local approaches, 2 or more local health departments. We intentionally haven't put a number on how many, but 2 or more local health departments working directly with each other to share services and resources. So this is one way of thinking it, sort of the different tiers, if you will, where sharing can occur. Now, another framework we have that we have found to be useful is the different ways that sharing can occur between and among local health departments. When we started this work, 10 years ago, we were using the term regionalization, and that had everybody thinking that our work was about consolidation and mergers. Next slide, please. But that's not it at all. Sharing at the local level also can take many different forms. So yes, you can see on the right end of the spectrum that at this end, sharing does involve regionalization and consolidation. However, If you go to the left side, there's as needed assistance, and these tend to be informal, handshake agreements that occur all over the place, all the time with local health departments. Also, there could be services that are specifically and narrowly tied to a contractual agreement and maybe just one service or one staff member for particular activities. And these arrangements, in these arrangements, the health departments are really not integrated, if you will. And if they are, it's a very loose integration. But then we get to that next category where an entire program or entire function is shared. And we're moving into a situation then where there's more integration between the two, where maybe staff go back and forth. Maybe there is a site that is set up that serves more than one entity. This could look any number of different ways. Anyway, so this is, and the work that we do at the National Center for Innovation is really focused on shared programs or functions, more at the right side. Not to say that the left side isn't valuable. Those arrangements are, it's just that those tend to evolve much more readily, and because there's such loose integration, it doesn't necessarily require the planning and consideration that we see when we move to the right end of the spectrum. Okay, that is all I had to say about that. Travis, let's go back to you.
Awesome. Thank you, Grace. And I will now turn things over to Alicia.
Thank you so much, Travis, and thank you all for taking time out of your day to geek out with us and talk about data modernization. So overall, data modernization is a multi-sector effort, so common language is super important. And so we wanted to take time to pan out and just share a common understanding of what data modernization is. So ultimately, data modernization is an effort that aims to enhance public health data systems to be more accessible, flexible, equitable, and actionable. We want to get to a space in public health where we can be proactive rather than in a constant state of reaction, although that's a part of the reality. So overall, when we're thinking about data modernization, we really aim to improve the processes for data collection, sharing, analyses, to enable faster and more informed decision-making across public health systems. Next slide. There we are. To realize this, the CDC has launched a massive effort. So in 2019, the Data Modernization Initiative was really kicked off. This is a multi-year, multi-billion-dollar investment into public health and its data systems that sustain it at both federal and state levels. The ultimate goal, again, is to generate better, faster, more actionable insights to support informed decision-making and improve public health outcomes while in the state of emergency, although we hope to make this the culture throughout our common public health processes and our day-to-day work. But truly, this was birthed out of a desire to respond faster, to make sure we have data that provides actionable insights for equitable and urgent decision-making when needed. So this initiative is supported by the overall CDC public health data strategy, the 4 goals you can review there. And it aligns with the true definition of how we speak about data modernization at the national, state, and local levels to strengthen the core of public health data. And we'll talk about what the core public health data are in a few moments, to accelerate access to analytic and automated solutions, to visualize and share insights to inform public actions, and advance more open and interoperable public health data. Next slide. So that kind of describes the what of it all. So now let's get into kind of the how of it all. So we are all familiar with the Public Health Infrastructure Grant, and if you're not, we'll chat a bit about it here. So the Public Health Infrastructure Grant, or it may be referred to later in this webinar as FPHIG, is a significant investment designed to strengthen these systems across the board. It supports strategies including workforce development, foundational capabilities, building upon those, and of course, data modernization as well. So you can see strategy A1 aligns with workforce, 2, foundational capabilities, A3 is that data modernization component. The data modernization component of FPHIG really complements the objectives of the data modernization initiative as a whole by directly funding upgrades to public health systems. And this is in alignment with the concept of enhancing data interoperability. We must upgrade our systems in order for interoperability to be possible. The goal of A3 funds also is centered around increasing an agency's capacity for effective data management. And this spans across a few domains that we'll talk about shortly. But it's expansive when we're talking about data management. Supporting our ability to leverage insights and really drive public health improvements from a data-driven perspective. That's key to this effort. So we can move on to the next slide. So as an example of how this investment is being leveraged, I'll introduce the Public Health Data Modernization Implementation Centers program. This is affectionately known by the PHAB and collective team here presenting this webinar as B4. So we did not pull that out on the previous slide, but when we're talking about the Public Health Data Modernization Implementation Centers, we're talking about the B4 component of FPHIG. So really by integrating solutions, providing funding for the infrastructure, the CDC really leveraged a lot of collective feedback we've been hearing since 2019, since the publishing of strategies and the communication of this nationwide initiative, which was that, funding is great, but we face a plethora of problems in public health, and we need direct support. And the Public Health Implementation Center program is really an effort to address that component. So it's a multi-year program to public health agencies specifically to advance their data modernization efforts. We are leveraging implementation centers. There's 4 implementation centers total, 3 serving non-tribal public health agencies, and 1 specifically being launched to address tribal-specific public health data-related challenges. So these implementation centers we're coupling the expertise of our designated implementation centers to provide that one-to-one support with the necessary funding to get projects off the ground and to move them forward. So this is a combination of feedback, funding, and the broader effort around data modernization that's being funneled into this program, where we are marrying the need for personnel support and collaboration with experts and funding needed to procure and upgrade systems to make interoperability, that goal, make it realized throughout the life of the program. We can move on to the next slide. I'll cover this at a high level, but I know True is following up with some more in-depth discussion around the domains that the program is really centered upon. I know as we kick things off, I mentioned that data modernization is dynamic and it's expansive, and it touches several areas. And the key and core domain areas that we're focusing on in the IC or Implementation Center program is across people, process, governance, and of course, technology. And again, True will go in depth, but when we are centering the program around these domains and we speak about people, we're really talking about how we can support in the program our public health agencies' communication with external partners they may collaborate with. How do we facilitate change management? Data modernization is not just a technological advancement or technological changes, it's cultural changes. And so how do we discuss that? How do we talk about that? How do we train those staff that are so dedicated to public health efforts and in the thick of it in the day-to-day on how to use these emerging technologies? How do we provide education on the various health IT standards that are out there and new technologies and approaches? So that's really what we're talking about in the program and providing support to jurisdictions around the people component. When we look into process, we're really talking about ensuring alignment with policies across the board. So that's state regulations and federal regulations that may govern the data that we're looking to make accessible and communicate across broad audiences to drive data-driven decision-making. When it comes to supporting reporting and performance measurement, project management, really figuring out how we can establish processes that clearly define our return on investment, the gains we're seeing from pursuing data modernization efforts is an art in and of itself and is another component of data modernization that we're realizing through the program. When it comes to governance, we're really supporting through this program and many data modernization initiatives, but it's super concentrated in this program to assist with developing those policies and participatory frameworks, DUAs, consent management practices that really address some of the challenges that we often see in public health and can hinder some of the progress and gains that we may aim to make in a work plan or performance period. But sometimes the governance structures make that a bit more challenging. And I know True will dig into that a bit more. So when we're talking about addressing governance as a core domain of the program, we're looking into those things and providing one-to-one support on how to address those things. Assessing the role of state regulations and policy on data sharing practices, making sure that we are assembling and enabling a diverse data governance structure that can be flexible as we explore how we can make data work for us in public health. And again, teeter from reactive public health into that proactive space where we can forecast and address issues sometimes before they even happen. So I won't belabor that point. Technology, it's somewhat straightforward. There's not a lack of technology out there that can address the problems and challenges that we face in public health. The public health field has transformed into a domain that addresses a lot of complex socioscientific problems, and there's technology that lives that we can use and leverage. But sometimes it's the resource component and ensuring that we are aware, trained up, and leveraging the technologies that are available and that our people are up to speed. Our processes enable the leveraging of these different solutions, and our governance also supports us maximizing the technological gains we're seeing in our country and around the world these days. So I'll stop there and I will pass it over to True to move through a few more details around the people, process, governance domains, in addition to some others.
Thank you, Alicia. So Alicia did a great job going through and highlighting all of those domains. As you saw in the previous slide, technology was a little grayed out. And the purpose is because we have an entire session as part of this two-part series dedicated solely to technology. So we want to really touch on the other domains as part of this part one series and really dig into the technology as part two. But as you all saw as well, finance and sustainability across all of the domains. And as we all know who have worked in data modernization, whether new or older, we all know that even though we are talking about these pillars and these domains in the categorical sense, that really is an oversimplification, right? Data modernization is really a holistic process and effort that intertwines all of these domains. And sometimes it is not easy to delineate any of them separately. And so, as Walisha mentioned, data modernization was officially launched by CDC in 2019. But we all know that this is not a new concept. We have all been involved in data modernization for decades now. So when we talk about these challenges of data modernization, again, those are not new either. But for the sake of simplicity and to carry the theme of people, process, even governance, finance, and sustainability across these challenges, let's go through some of the major challenges that we have heard across the years when it comes to data modernization from public health agencies. And again, this is, just a small list. By no means is this extensive at all. And so first, in talking about people and workforce, we hear a lot that there are workforce limitations. Recruitment and retention amongst public health agency has been difficult, especially with the onset of the COVID pandemic. One of the things that has also been a challenge is once you recruit and train your workforce, how do you ensure continuity, whether it's the redundancy of skill sets and competencies across team members, but how do you also, ensure succession planning as well? So as you have attrition, as you have people either retiring or leaving, that you maintain that in-house knowledge. And that really is important, especially for concepts around data modernization like standards and data exchange. And so when we talk about processes, a lot of challenges that we hear over and over again are competing priorities, especially in the face of emerging emergency events. So for example, when COVID pandemic came around, everyone had, multiple full-time jobs, right? Not only dealing with the pandemic, but also dealing with the day in and day out of core public health activities. But as part of data modernization, as you develop and implement new processes, how do you then get buy-in, right? Especially buy-in from that workforce that needs to be able to implement it and needs to be able to standardize it so that it is part of their day in and day out work planning. And then as part of standardizing the processes and buy-in as well is change management. It is such an important part of data modernization because, as Walisha mentioned, many times it can be a culture change. It can be a culture shock when you have processes that have been well ingrained now being replaced by new processes that team members have to relearn and retrain on. And for governance, we hear a lot now about data governance as part of data modernization, but it is organizational governance, it is IT governance, it is data governance, it is the structure and framework of how decision making is implemented. And having those data governance processes and even organizational IT processes in place is crucial for data modernization because it allows you to be efficient in making sure that all the voices are heard and that you have really that buy-in from leadership all the way down to your workforce as well. Another challenge that we hear often a lot is legal challenges, especially with smaller local health departments. Sometimes there is not enough legal capacity to be able to look through all of the documents or new efforts that may need their buy-in and support or risk assessment. And then also public and private partnerships. as Alicia mentioned, part of data modernization is being able to share data, not only in a unilateral direction, but also bidirectionally back to who gave us the data. And as part of that, it's sharing data within our agency and departments, with neighboring agencies and departments, and also with healthcare providers as well. And so establishing those relationships, establishing that trust so that we can then support each other in moving data quickly, cleanly, accurately is vital for this effort. And then finance and sustainability are, of course, as we mentioned, really all encompassing. You have to have finance to make sure that all the other domains run. So how do you fund these efforts, these data modernization efforts, and then maintain them once they're started up, once they're implemented, and they need to continue, right? And then how do you also work with other departments, other neighboring agencies in order to ensure that those processes are maintained and sustained, whether it's through grants, whether it's through tax dollars, pass-through funds, et cetera. And then sustainability. Once you implement a data modernization process enhancement system, how do you make sure that once it's implemented, it stays there? And that's operation and maintenance of that technology, which we will also touch on in the later series. But how do you maintain those gains and not revert backwards to previous methods? And then also, just as important is, how do you sustain those and then scale them to other use cases so that, for example, if you have a system that was implemented for one use case, being able to leverage on those gains as an enterprise-wide solution so that you can leverage on that and be able to use that internal investment for other processes as well. Next slide, please. So what is the role of services and resource sharing for data modernization? It plays a really critical role for DMI, especially for local health departments, for providers, because public health at its core is really a grassroots effort, right? Your healthcare providers are collecting that data, your local health departments are also collecting that data, and they are analyzing, they are cleaning it, and it moves through the local, state, federal levels as well. And what I don't have on this great ripple figure is that bidirectionality, right? So as the data aggregates and accumulates at scale, it accumulates in volume, accumulates in quality and completeness and timeliness. So as that all improves at the provider level, at the local level, at the community level, it also improves at those higher levels as well to inform population health. And as population health is informed, all that decision making that relies on it is also improved with accuracy, completeness, and timeliness as well. So at the local health department level, a recent profile report from NACCHO indicated that 57% of all health departments are actually working on data modernization efforts. However, it is skewed a little bit more towards larger urban area health departments, which may have more resourcing than smaller rural area health departments. And so that's where resource sharing really comes in play, and we'll talk about the benefits here, where smaller rural health departments can leverage a lot of the lessons learned and the gains through resource and service sharing. And then as part of that, as we mentioned, not all health departments are sufficiently resourced for data modernization. So being able to understand those success stories, those lessons learned will really help to accelerate data modernization across all of these levels. Next page, please. So what are the benefits of services and resource sharing specifically for data modernization? Well, across all levels, especially local health departments. For personnel, you can certainly share staff resources between public health agencies, especially smaller rural public health agencies that may not have the capacity to perform all services, especially in an emergency event. It can also provide opportunities to train on new capabilities. One public health agency may have, you know, training resources or expertise in a certain area that another may not, that they can partner and be able to share a lot of those skills and trainings on. For processes, resource sharing and services sharing can support best practices and success stories for data modernization. That is really critical as we move forward with this. It helps morale, and it also helps us learn some of the challenges and pitfalls that we can avoid as a public health community. It also helps to improve efficiency as well, so that we're not experimenting different processes that may or may not work. Actually, a study across 230 local health departments across 4 states published in 2016 found that of the local health departments that were employing service and resource sharing, that most of them saw improved resources and service sharing, and were much more efficient, especially across communicable disease reporting. And then there's also the bandwagon effect. With the bandwagon effect, we see that as one local health department does, a data modernization process that shows gains and successes, the neighboring local health departments often pick up on it as well, just due to mere communication and proximity. For governance, implementing or expanding on new partnerships or existing partnerships is really important, and can be a great part of resource sharing, especially as partnerships that have been very successful in one part of the agency or for another jurisdiction can be leveraged for another part of the agency or another jurisdiction as well. And then improve data sharing. So as we create new partnerships, we can improve the quality and quantity of data that we are sharing to support population health. For finances, there are shared costs that can reduce financial burden, especially with braided funding or sharing with other jurisdictions. And then shared lessons learned can reduce costly experimentation as well. And for sustainability, we can enhance scalability and sustainability between jurisdictions that are sharing lessons learned or even best practices. And there may not need to be any experimentation, that you can leverage tried and true models. And then there's also, as part of that study, an outcome linked to improved healthcare and population health among those communities. Next slide, please. So here's where we get into some examples. And these examples are really intended to show how resource and services sharing can be implemented across scale, whether it's at local health departments, at territories or state levels, or at regional levels, to address challenges that are all too familiar for data modernization. So the first example we want to point out is Massachusetts. So Massachusetts has more local health jurisdictions than any other state at 351. And most of these municipalities stand alone, but they were not able to keep up with their growing list of responsibilities, including meeting statutory requirements and workforce capacity to meet rigorous national public health standards. So what did Massachusetts do? Their Office of Legal and Regional Health at the state provides more than $50 million in grants through its State Action for Public Health program called SAFI to increase cross-jurisdictional sharing of public health services through all of their local health departments. So this includes a consortium or in collaboration about 51 across cities and towns to improve compliance with meeting public health standards and data modernization across different core public health activities such as disease surveillance, case management, and data reporting. The state also provides training courses online for modernization topics, including HL7 data standards. Next slide, please. So here's another example. Across the Commonwealth Northern Marianas Islands and their CHCC Public Health Department. So CHCC does have a core IT team, but they often experience challenges with their EHR systems in receiving data, retrieving it, and reporting it across all of its public health activities. This was absolutely exacerbated during the COVID-19 pandemic when they had to collect and report on really time-sensitive data, and their IT really had difficulties in supporting it. So CNMI put together a multidisciplinary task force across police, fire, also with their tourism board, et cetera. And they partner with a private firm to deliver across technology systems and implement electronic forms, which really automated a lot of their data collection processes for lab reporting, border monitoring, quarantining, and vaccination. As a result, the process and technology was so successful that it was then reused for CHCC's non-communicable disease program, such as diabetes reporting, saving time and money to sustain and improve other use cases as well. So they were able to really leverage one solution and implement it as an enterprise strategy. Next, please. So my last example, and then I'll pass it to Alicia, is with APHL's regional consortium that they have with the public health laboratories across states. So there was really a need back in, I believe, the 1970s to find a collective approach amongst public health laboratories and its community to enhance workforce development and capacity to ensure continuity of operations, particularly during emergency outbreaks, while addressing the unique public health challenges at each of the regional levels across the states. So APHL, with support from CDC, assisted in the development and continuance of 7 consortia across the US by really identifying their needs and resources, and then also facilitating their coordination and providing innovative grant awards to maintain this consortium. The regional consortia do meet together to provide subject matter expertise and best practices, but they also provide to each other emergency test support, shared services, and resources to each other, including lab equipment and supplies to enhance lab services across the region. And that really, we saw that across the pandemic. And each regional consortia also maintains its own governance structure. So these examples, again, are really to show you how shared resources can be implemented at scale for some of these DMI challenges. Now I'll pass it to Alicia to share some of her examples as well.
Thank you so much, True. And it'll just be one example because I know we have 15 minutes left and want to dive into Q&A. But I did want to share an example that kind of touches on some of the points that True made in her presentation around the importance of collaboration and braided funding. So the North Carolina Division of Public Health State Center for Health Statistics encountered a challenge during the COVID-19 pandemic, where we realized that critical data gaps in our data infrastructure really hinder data-driven decision-making around emergency response. We recognize that historically marginalized populations were disproportionately impacted by the pandemic, funneling out a lot of money and effort on resources to address that disparity. However, despite the issuance of large amount of resources targeted to address the disparities of these populations, there were still some gaps. We were still seeing those disparate outcomes throughout the progression of the pandemic. So the North Carolina State Center for Health Statistics initiated an effort to leverage braided funding structure and collaborative solutions. So the braided funding structure came from an investment from federal funds supporting COVID-19 efforts, as well as communicating a need and seeking collaboration with philanthropic organizations. Through that effort of communicating the need and emphasizing the importance of a collaborative effort, leveraging those we felt knew the most about our historically marginalized populations in North Carolina, we were able to acquire enough funding to launch the HBCU Equity Data Consortium. This consortium leveraged academic institutions, as we had minority serving institutions and HBCUs across every region, in roughly every Medicaid region in North Carolina. We leveraged that funding to engage all of these entities as we realized throughout the pandemic that we saw the most benefit and the most advancement of COVID-19 emergency response coming through these sectors. We were able to fund this consortium, create a model by which the HBCUs collaborated with community-based organizations in their respective regions to fill these data gaps. And over the course of 1.5 years, we were able, for the first time in North Carolina's history, to collect qualitative data from all 100 counties across the state by leveraging this collaborative model and seeking investment not only from federal funders, but also philanthropic organizations. So this is a concept that was pretty novel in that it was rather creative to seek funding outside of our traditional avenues, and being a bit creative in leveraging our academic institutions and resolving some of our public health data related challenges enabled us to accomplish a milestone that hadn't been done before, and expresses much potential of how these collaborations can expand from the opportunities that have been birthed out of this effort to pursue more academic local health departments, whereby we connect students to provide staffing support, but also gain a lot of applicable workforce knowledge through collaborating and working with local health departments through this consortia structure. So just wanted to share that example. I know we're heading into Q&A, so I'll pass it over to Travis. Let it take up too much time there.
Well, thank you all for sharing those wonderful examples. I really appreciate you taking the time to dive into those a little more. So before we actually transition to Q&A, I did want to give you all a quick moment just to share maybe any next steps you recommend or actions participants can take with their service resource sharing or data modernization efforts. So I think I'll start with True, and then we'll see if Alicia and Grace have anything to add.
Thanks, Travis. So, one thing that we do recommend is, as you're looking into shared services and resources, looking at collaboration models that have really been successful. So that may be looking at success stories, seeing, I see in the chat here, what are the factors that really led to their success? So, maybe reaching out to them to see what their success factors were, why it was successful. But also, one study I read was that I think around 60% of shared resources and services were really handshake agreements, like Grace had said. So if you have a partnership that is already successful and already works, really leverage on that. See how you can grow it, see how you can expand it to include other use cases, bring in other groups in there as well, because that's already an organic relationship that has worked. And then lastly, really talking to your other jurisdictions to see whether they have a consortium model or whether there's any funding for it as well.
Absolutely. And just to piggyback off of what True said, I found the most effective models were where folks pursued like local collective action, just kind of assessing the different data that are out there that are being leveraged by multiple entities, where impacts are cross-cutting, and really telling the story to those that make decisions about how addressing one particular problem can address concerns, and hit on points and other downstream effects that affect the collective as a whole. So really doing the work of organizing yourself to be able to pursue collective action, be able to tell those cross-cutting stories, oftentimes garners a lot of attention, and can quickly advance things. As more voices come together, we begin to see more action and more rapid decision making.
Thank you. And Grace, see if you want to add anything, or if you want to add to what Phyllis asked in the chat about some success factors that have helped arrangements succeed, and any tools or templates you may recommend.
So I don't have anything to add to that, but hello, Phyllis. And with respect to Phyllis's question, we do have the National Center for Innovation. We have a document called Factors for Success in Sharing Arrangements. And I'll just see if I can do them from scratch, but there are 3 prerequisites, and these are things that really need to be in place before you can really successfully share. And that's having a shared, having clarity of objectives, and having a good sense of trust among the partners, and also making sure you're taking a balanced approach. So you're looking both to be efficient and effective, that those are relatively equally weighted. We also have factors to that you can leverage if they are present, and that's those are positive interpersonal relationships, a good history together, kind of building on what worked in the past, as well as if there's a regional identity, really capitalizing on that. Thanks for sharing that, Travis, in the chat box. And then finally, basically project management characteristics. Make sure that you treat this as a project, that you have senior level support, that you develop a change management plan for the employees. True was talking about that earlier, that you also communicate broadly about the sharing arrangement with all the appropriate folks, and also that you have evaluation measures that you put into place. So that's what I have. And it looks like it would be helpful for Phyllis if True or Alicia could speak to anything specific or unique to data modernization that would be important to know, like any nuances to our more generic approach, anything specific to data modernization. Thanks, Phyllis.
Yeah, and to address Phyllis's question, one thing I'll add, and then I'll punt it to Alicia, is in regards to data modernization that may make it a little bit more complex, is that oftentimes you have the facet of data, so data privacy, security, data use, data governance, but you also have technology, right? So that can include cybersecurity, service level agreements, a whole IT group as well. So ensuring that those groups are involved as well, understanding what their needs are, that they are also a partner at the table. And it could be that the shared resources benefit them. If you have an IT that is centralized, that may not have the capacity to address all of your novel data modernization needs because it's added effort along with what they normally have going on, then that may pose as a rate limiting step. And it may be good to see where you can form a collaborative or tap a consortium or even have a local, informal handshake agreement to support those needs. And from the data governance side, that is really important and a crucial part of modernization, because it's the who, what, when, where, why, and how around data. And because of the sensitivity of the data, there's also the legal component of the data as well that needs to be incorporated. So leadership needs to be involved. Your legal attorneys need to be involved as well. And, understanding the capacity levels and what the resourcing and shared services needs are for that. Alicia?
Yes, we are of the same mind, which commonly happens with Drew and I. I would say, we have to remove, in data modernization, we have to remove myth from reality. So being aware of the laws that govern the data that you're seeking to modernize is critical. A lot of times, things change over time, and the powers that be are not aware of the pivots in policy and statute shifts. And sometimes it can be an opportunity to educate in that space. Also, with us being data-driven folks, the majority of us on this call is like, hey, it's simple, it's the data, it is what it is, like, hello, this makes sense. But we do have to get creative in our storytelling. That is another component, speaking to True's point, to get that buy-in, to create this collaborative where all voices are heard and you can communicate the add benefit of pursuing a project across these different sectors within your institutional structure is critical. Again, a lot of us in public health have transformed from being strictly an epidemiologist or a data analyst to really being an informatician across the board. And a lot of folks aren't clear on how rapidly the public health industry has transformed and the level of knowledge and expertise that we hold as practitioners on the ground in the day-to-day. So we have to be creative in how we communicate those stories, being aware of each audience and what matters to each. And as we're advocating for change, being sure you're addressing the concerns as well as the desires of those entities that are needed to get the buy-in that you need. So adding that level of creative storytelling is not something, I was horrible at it. I was like, why don't we get this? Like, hello. But it is a component that I think is understated in data modernization, the level of creative storytelling and making those connections and how important that is at getting an initiative off the ground.
Well, thank you all. And Phyllis, no worries for the questions. For this last one you have, we'll make sure we'll follow up with you directly, just because we are almost at time and do have a couple more slides to run through. But for other folks on the line, if there are other questions you may have, feel free to put them into the chat now. We'll make sure we address them. And then also you'll see on the screen momentarily an email address too that you can reach out to us. And if you have any questions from today, we'll make sure we'll get those answered. But in our last couple minutes, I did want to just share a couple more things with you all. So on the screen, you'll see some of the ways that PHAB can support you in your capacity building needs. So through some strategy and implementation consultation and facilitation that we provide, we can assist with diving into your specific data challenges to explore some root causes and then maybe how service and resource sharing could be a possible solution to address those challenges. And then through our tools for transformation that we have available, and we'll make sure we send those along to in a follow-up email, we can support you in your data modernization efforts with service sharing, either through a lens of service and resource sharing or as a possible solution. And then as Alicia and True mentioned a couple times, if you are a FPHIG recipient, there is some technical assistance available through the IC program. And again, feel free to reach out through that email address on the screen if you have questions or want some more information. So we do have a lot of service and resource sharing resources available, including some general fact sheets, some assessment tools, and some sample agreements, as well as several success stories on how public health entities have collaborated to improve health outcomes. We do hope you take a look at these and utilize them and read the stories, and we hope they are helpful in your work. I'm recognizing that you can't click on these now, but we'll share the slides in a follow-up. Here are just some important links that we would like you to take a look at when you receive that follow-up. And then lastly, as we've alluded to a couple times, we have some upcoming events, including the part 2 for this webinar on December 17th. So hopefully you'll join us in about a month or so to learn more about the technology aspect of data modernization. So again, thank you all for joining today's session. We hope it was informative and it does allow you some applicable ways to support your work and efforts. Please join me in thanking Grace, Felicia, and True for presenting and doing an amazing job today. Really appreciate their time and expertise. Please be sure to connect with PHAB through the social media accounts here on the screen. And you can take a brief evaluation either by pointing to the QR code on the screen or through the link that is in the chat. And if you are not already signed up for our e-newsletter, you can use the QR code here on the right side to be added to our distribution list and keep up to date on all things PHAB and all the events that we have available. So again, thank you all for your participation today. Really appreciate the time, and you may now disconnect.